Welcome back to the Deep Dive. Today, we are stripping away the basics. We aren't here to teach you how to put on a cervical collar or, run a primary survey.
No.
If you're listening to this, you likely already know how to save a life in your sleep.
Hopefully.
Today, we are looking at the high-level architecture of decision-making. We're focusing on the Southwest Peninsula Trauma Network, or PTN, and specifically, the Golden Hour's new rules of engagement.
Exactly. We're looking at the strategy behind the resuscitation because, let's be honest, for a long time in the UK, trauma care was, well, it was a bit of a lottery.
It was reactive.
Completely. You see blood, you stop it. You see a hole, you plug it. But what we're digging into today is the evidence-based framework that dictates when you summon the cavalry versus when you hold the line with your ED team.
And to really appreciate where we are now, we have to look back at the bad old days. I was reading through the background notes. And that 2007 NCEPO report really sets the scene.
Oh, yeah.
It was titled Trauma, Who Cares? Which, let's be honest, is not a subtle title.
No. It's practically an accusation. It was a slap in the face for the entire NHS. It wasn't rhetorical.
Not at all.
That report found that nearly 60% of trauma patients received care categorized as less than good practice.
Which is a very polite way of saying we were failing more than half the time.
We were. The model back then was just nearest hospital wins. It didn't matter if you had a complex intracranial bleed and the nearest hospital was a cottage unit with no neurosurgery.
That's where you went. It seems wild in retrospect.
It does. But that report triggered the massive overhaul we see today, the move to the regionalized trauma network system around 2012.
And looking at the data, the payoff has been incredible. A 19% case mix adjusted increase in survival odds.
It's huge.
In public health, you almost never see double-digit improvements like that.
It's the difference between system design and luck. But, and this is the crux of our deep dive today, that system only works if the front door is calibrated correctly. The whole system relies on the senior clinician making the right call on trauma team activation, or TTA. If you undercall it, people die. If you overcall it, you burn out the system.
So let's get into the weeds of the Peninsula Trauma Network.
Yeah.
They don't use a binary team or no team model. They use a tiered system. Specifically, if we look at major trauma centers like Derriford, they're in a Tier 1 and Tier 2 response. Why the complexity? Why not just all hands on deck for anything that sounds scary?
It's purely a resource balancing act.
Right.
Think about the cost, not just financial, but operational of a full code red. You are pulling a consultant anesthetist, a consultant surgeon, radiology, senior nursing staff.
Well, out of their respective areas.
Exactly. And if you do that for every single high mechanism injury, you grind elective lists to a halt, you burn out your consultants. The tiered system is designed to protect the hospital's capacity while keeping the patients safe.
Right. So Tier 1 is the ED trauma team. This is essentially the safety net.
Exactly. Think of Tier 1 as the filter. This is usually triggered by a significant mechanism of injury, say a high-speed rollover on the A38, but the patient is physiologically stable.
Okay.
The team is leaner, a senior ED clinician, nurses, a scribe. The mission here isn't fix everything immediately.
No.
The mission is a rapid primary and secondary survey to catch what we call candidate major trauma.
So you're looking for the hidden injuries without mobilizing the neurosurgeons and orthopods just yet.
Correct. And the data backs this up. Evidence from the PTN shows that patients triaged to Tier 1 rarely require immediate life-saving surgery or ICU admission.
So it works.
It works. And from a management perspective, Derriford estimated this tiered approach saves about $180,663 per year by avoiding unnecessary full activations.
Wow, that's a salary too right there.
It's significant.
But then we have Tier 2, the hospital trauma team. This is the code red.
This is the big one.
This is when the TTL, anesthetics, surgery, and radiology all descend on the resus bay.
This is for physiological instability or high-risk anatomy. But here is where the decision-making gets really, really difficult for the senior doctor.
How so?
Well, we've all been taught since medical school that a systolic blood pressure of 90 is the panic button. Below 90 is shock.
Of course.
But the sources for this deep dive suggest that relying on 90 is basically setting a trap for yourself.
Okay, let's unpack that because it's a hard habit to break. Why is 90 a trap?
It's the classic problem of a marker being specific but totally insensitive. I mean, if your SBP is 80, yes, you are undeniably in trouble.
No question.
But if it's 110, it absolutely does not mean you're fine. We need to talk about physiological reserve. You take a 20-year-old Marine, They can lose 30–40% of their blood volume and still chat to you with a BP of 110.
Because their catecholming surge is just clamping down on everything.
Everything. Every peripheral vessel they have.
They'll look fine, look fine, look fine.
Until they fall off a cliff. Precisely. They are stable right up until the moment they arrest.
And by then, you're way behind.
You are. The data shows a linear trend. Mortality actually starts increasing as soon as the SBP drops below 110 mmHg. By the time you hit 90, you've essentially missed the boat on early intervention. You're playing catch-up.
And this gets even more critical and, honestly, more terrifying. When we talk about the specific demographic in the Southwest, we aren't just dealing with young Marines.
No, we are dealing with the silver tsunami. This is the massive shift in UK trauma. The typical major trauma patient is no longer the high-speed car crash victim.
No, it's the 75-year-old who fell down the stair.
Exactly. And their physiology is a completely different beast.
Okay, let's run a scenario. You have 75-year-old male, fell from standing height, SBP is 120, heart rate is 80.
On paper, looks textbook normal.
Yeah, I'd be happy with those numbers for myself. So is he stable?
And that is the trap. In a geriatric patient, that normal profile is likely shock.
Really?
You have to factor in two things. First, age-related arterial stiffening. Their baseline BP might be 160 or 170, so a drop to 120 is a massive relative hypotension for them.
They've lost perfusion pressure.
They have. And second, look at the medications. If they are on a beta blocker like bisoprolol, they physically cannot mount a tachycardia. Their heart rate is capped at 80 regardless of how much they're bleeding.
So the classic signs of shock tachycardia and hypotension.
We're completely masked. Exactly. They don't look sick until they are dying.
So what is the new rule? How do we catch this?
The 110 rule. The evidence demonstrates that for patients over 65, a systolic BP of less than 110 carries the same mortality risk as a BP of less than 90 in a younger patient.
But hold on. 110 systolic is incredibly common in the ED. If I trigger a full Tier 2 trauma response for every 75-year-old with a BP of a 105, am I not just going to gridlock the department?
The surgeons might hate you initially, yes.
They hate me.
But you have to show them the mortality curves. You are trading popularity for survival. If you see a geriatric patient with a mechanism of injury and a BP of 105, you have to treat that as a major hemorrhage until proven otherwise. The risk is just too high.
So if the vital signs are lying to us, particularly in the elderly, is there a truth teller? A metric we can trust?
Lactate. It is the critical discriminator. We call it a cult shock. If you have a patient with normal vitals but a lactate greater than 2.5 millimoles per liter, their cells are starving.
They're hypoperfusing.
Yes. That number cuts through the beta blockers and the arterial stiffening and tells you the metabolic truth.
I want to quickly pivot to the other end of the age spectrum, pediatrics. Because with the elderly, the physiology lies because everything is stiff and unresponsive.
Right.
But when you flip the script and look at kids, the physiology lies for the exact opposite reason.
Right. Their tank is full. Their pumps are pristine. In children, hypotension is a pre-terminal event. A child can maintain their blood pressure until they have lost 40% of their circulating volume.
So if you wait for the BP to drop in a kid,
you are essentially waiting for cardiac arrest. You've missed the window.
So for the senior doc, what's the trigger then?
You have to ignore the BP cuff and look at perfusion, capillary refill, SIN modeling, core peripheral temperature gap, and look at the age-adjusted heart rate. Tachycardia is the only early warning you get.
Let's move to anatomy. Sometimes the physiology is fine, but the injury itself is just a screaming red flag.
100%. The PTN guidelines are pretty clear on high-risk anatomy, specifically penetrating central core injuries.
The box between the knees and the elbows.
That's it. If something penetrates the torso, neck, or proximal limbs, it's an automatic Tier 2 activation. It doesn't matter if they're talking to you. The predictive value for needing immediate surgery is just too high to gamble on.
And then there are pelvic binders. We see these come in from pre-hospital all the time.
And we should treat them as a surrogate marker for massive retroperitoneal hemorrhage. If the paramedics thought the pelvis was unstable enough to bind, you assume they're bleeding into that massive retroperitoneal space until a CT scan proves otherwise.
That's a code red.
It has to be, purely because if they were bleeding, they can exsanguinate into the pelvis before you even see a drop of blood on the floor.
Going back to our silver trauma group, there are some anatomical injuries that don't look dramatic, but are statistically lethal.
Rib fractures. This is the silent killer in the elderly. In a 25-year-old, 3 cracked ribs is painful. In an 85-year-old, it's a potential death sentence.
Why?
The pain leads to splinting, which leads to hypoventilation, which leads to pneumonia and respiratory failure. It's a slow, predictable spiral.
And then there's the anticoagulation issue, warfarin, apixaban.
The rule in the Peninsula Network is low threshold. If an elderly patient on blood thinners has hit their head, they get a CT head, period. It doesn't matter if their GCS is 15 and they are chatting about the weather.
Right.
Intracranial bleeds in the elderly can expand rapidly, and because of brain atrophy, they have more space to fill with blood before they show symptoms. By the time they cone, it's too late.
Okay, so we've triggered the team. The patient is in the bay. Now we are in the golden hour proper. Let's talk about the senior doctor's role in resuscitation. We hear damage control resuscitation or DCR a lot, but what does that actually mean for the person running the room?
It means reversing the physiology of death. The lethal triad, coagulopathy, acidosis, hypothermia. Your job is to stop that cycle.
Which starts with fluid management, or rather, fluid restriction.
Correct. We have moved away from fill them up. If you pump a bleeding patient full of saline or Hartmann's, you are diluting their clotting factors and you are making them acidic.
You're literally making the bleeding harder to stop.
You are. We aim for permissive hypotension. Keep the SBP around 70 to 90, just enough to create a palpable central pulse until the surgeon can plug the hole.
Don't pop the clot.
Don't pop the clot. If you push the BP higher, you restart the bleeding.
And if they do need volume?
Give them blood, 1.1.1 ratio, plasma, platelets, red cells. Make the fluid you put in look exactly like the fluid that leaked out.
Now, this is where I want to get into the psychology of the senior doctor, the role of the trauma team leader, the TTL. The sources are very specific about the hands-off rule. Ideally, the TTL should not touch the patient.
This is the hardest shift for a senior registrar stepping up to consultant, isn't it?
Oh, absolutely.
You've spent 10 years being the best pair of hands in the room, cannulating the impossible veins, tubing the difficult airways. Suddenly, the best thing you can do is put your hands behind your back.
It feels wrong.
It feels passive. But the data is brutal on this.
It is.
The moment the team leader picks up a laryngoscope, their situational awareness drops by something like 60%. You stop running the room and start running a procedure, you get fixation error.
Right, you're staring at the vocal cords. Meanwhile, the patient is exsanguinating from a femoral fracture that nobody has noticed because the leader is busy intubating.
It's all about cognitive bandwidth. The TTL needs the helicopter view. They are there to synthesize information, anticipate the next step. Is blood bank here? Is CT ready? And manage the team.
And the outcomes are better.
Consistently. Consultant-led teams where the consultant remains hands-off achieve faster times to CT and to theater.
This brings us to non-technical skills, or NTS, the TNO-TechS framework.
Which sounds like management speak, but it's vital. It covers leadership, communication, situational awareness. A key practical tool here is the pre-brief.
The huddle before the patient arrives.
Yes. Before the patient rolls through the doors, the TTL needs to establish a shared mental model.
I am the leader. Dave, you are airway. Sarah, you are circulation. If the patient is unstable, we bypass CT and go straight to theater.
Precisely. It prevents the chaos of the crowd around the bed. It means everyone knows their lane before the stress hits.
Let's shift gears to the administrative side, the mathematics of safety. Senior doctors have to audit their department's performance. We see this term Krigari matrix and discussions about under-triage versus over-triage.
Right. This is where we measure the cost of our decisions. It's a trade-off. In an ideal world, we'd get it right 100% of the time.
But we can't.
We can't. So we have to choose. Do we want to risk missing a major injury, or do we want to risk calling the team for a minor one?
And the system has a very clear preference.
Absolutely. The goal is to keep under-triage missing a major injury below 5%. Because if you miss a splenic rupture or an epidural hematoma, the patient dies. That is unacceptable.
But the cost of that safety is over-triage.
Correct. To catch all the bad ones, you have to accept an over-triage rate of 25% to 50%.
So up to half the time you call the full Tier 2 team, the patient turns out to be fine.
Yes, and I think this is really important for listeners to hear, because there is a sense of shame or at least awkwardness. When you call a code red, everyone rushes down and the patient is chatting and eating a sandwich.
You feel like you've wasted resources.
It's not waste, it's a safety tax. It's the insurance premium we pay to ensure we don't miss the one patient who is quietly bleeding to death. It is far better to stand down a team than to scramble one when the patient is already crashing.
However, there is a statistical trap here that senior docs need to watch out for when they are doing their audits. The statistical fallacy.
Right, this is the denominator problem. Imagine you work in a busy ED that sees thousands of minor injuries walking wounded, twisted ankles. If you include all those minor patients in your trauma data set, your total N number is massive.
So the denominator is huge.
Exactly. So even if you miss 3 or 4 major splenic ruptures, which is a clinical disaster, those 3 cases get drowned out in the sea of minor injuries. Your percentage looks great. Look, we have a 0.1% under triage rate, but clinically, you still failed those 3 patients.
You have to strip out the noise to see the signal.
You do. You need to calculate sensitivity based on the relevant population, not just everyone who walked through the door.
That is a crucial distinction. Don't let the walking wounded hide your mistakes.
Precisely.
So as we wrap up, let's look forward. The 1 in 10 rule is changing practice now. The network is established. But what's on the horizon?
Well, technology is finally catching up to clinical judgment. We're looking at machine learning, specifically random forest models, that are showing 80% accuracy in predicting who needs a trauma team.
Wow.
These models can take demographics, mechanism, pre-hospital vitals, and give you a risk score that might eventually replace our current, more blunt tools.
Imagine an AI flagging that stable 75-year-old with the BP of 105 before they even arrive, purely based on the pattern of data.
It would take the emotion and the hesitancy out of the decision. It's very exciting stuff.
So to bring this all back home for the consultants and registrars in the Peninsula Network, let's recap the golden rules.
Okay, number 1. For the elderly, 110 is the new 90. Do not be fooled by normal blood pressure.
If they're over 65 and the BP is 105, they are in shock until proven otherwise.
Number 2, lactate finds the truth. Use it to cut through the physiological compensation and find the occult shock.
Number 3, the TTL leads. They don't treat.
Sit on your hands so you can use your brain. Situational awareness saves more lives than a perfect intubation.
And finally, embrace over-triage. It is the cost of doing business safely.
Don't apologize for calling the team and finding nothing. Apologize for not calling them and finding a disaster.
Spot on. I want to leave everyone with a final thought from the source material. It's the concept of functional inclusivity.
This is a really provocative idea for the future of the network. Right now, we focus heavily on mortality, did they survive? But functional inclusivity asks, is the right patient in the right hospital for their specific injury profile?
Meaning, are we just dumping everyone at the major trauma center because it's the safe option?
Exactly. Functional inclusivity is about keeping local units active for appropriate cases, the isolated limb fractures, the less complex trauma, while strictly preserving the MTC for the true life threats.
It raises a question for every department.
It does. Are you sending too much or are you holding too much?
Getting that balance right is the difference between a functioning network and a gridlocked one.
And that is the next frontier.
A fascinating deep dive into the mechanics, physiology, and strategy of saving lives in the Southwest. Thank you for walking us through it.
A pleasure.
And to our listeners, thank you for what you do. We'll see you on the next deep dive.